The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Welcome to Your Health, Your Choice. This program is going to be played in the week, Wednesday night, Wednesday the 20th of May, and then be repeated next week. So, Your Health, Your Choice. We've been doing this program for many years, and by the way, my dear wife Linda is not with me tonight. She usually lights up the program, and we have lots of good banter, sometimes some disagreements on points of science, but I'm doing the program on my own tonight. We have been doing this program for quite a few years, and Your Health, Your Choice, the meaning of that, or what we talk about in this program, is really empowering you to make wise decisions about your health. Now, sometimes we may talk about controversial topics, but we are coming from a scientific point of view. I do end the program by putting on my pastoral hat because, as many of you know, I'm co-vocational medical doctor as well as a pastor. But the main aspect of the program is the scientific basis in the approach and the practice of medicine, and trying to empower you to make the right decisions. Now, over the last few weeks, we've been spending the first part of the program talking about COVID-19. And of course, we are still here in Trinidad to be quite fortunate in that I think our cases are still at around 116, with still just 8 deaths. And progressively, the restrictions are being relaxed, and hopefully over the next few weeks, we'll move on to phase 3, phase 4, phase 5. And my personal opinion is that the true test will come when we decide how and when the borders will be reopened. I just want to point out a few things, the latest news circulating about COVID-19. I read yesterday, and this is not to put any fear in the lives of our diabetics who are looking, because I know many of my diabetic patients look at the program, but 25% of people who died of COVID-19 in hospitals in the US and the UK had diabetes. Now, this does not say that the diabetes itself caused the death, but there's an association. So this is the one thing about science. You have to be careful about something causing another problem, causing death, or something being associated with it. So what we know now is that 25% of people who died of COVID-19 also had diabetes. So there's a kind of red flag there, that people with diabetes are at a higher risk, as I said last time, of developing complications if they contract COVID-19. So we're not saying necessarily that diabetics are at a higher risk of getting COVID-19, but if they do get COVID-19, they may be at a higher risk of getting complications. And of course, we know there's been a lot of discussions about ethnic minorities, especially in the US, the Afro-American population, and in the UK, which I've been following very closely, especially with respect to doctors of ethnic minorities. The majority of deaths amongst doctors and healthcare professionals in the UK has been among those of ethnic minorities. And this can be attributed to, in some cases, hypertension, diabetes, lung disease, obesity, and other comorbid conditions. But there's still a lot of investigations being done around that. And just this morning, I was on a Zoom call with several of my colleagues in the UK, and there's now a risk stratification. It's called Eclipse, I think, a risk stratification for patients as well as healthcare professionals to see what is your risk if you're coming in contact with patients with COVID-19. So people with diabetes, we need to optimize their glycemic control. So even in the midst of this pandemic, we should still be seeing our diabetic patients. I'm still seeing my patients, and we are still trying to emphasize the basis of good blood sugar control, good blood pressure control. So if, God forbid, you were to contract COVID-19, you have a better chance of surviving and not developing complications. The other big thing about COVID-19 is a vaccination. Now, I just want to say there's a lot of controversies, there's a lot of talk, a lot of conspiracy theories about when if a vaccination is developed. There's a lot of stories about Bill Gates and his motivations to try and push the development of vaccinations. I know I was quite strong on the last program, so I'm going to try and be careful how I put this across. My personal opinion, as a medical doctor, as someone trained in the science of medicine, that the solution to dealing with COVID-19 is the development of a vaccination. Now, we may get drugs. There's still several drugs, as we said 2 weeks ago, remdesivir. I'm going to come to chloroquine in a few minutes. But a vaccination is, I believe, what we really need. Now, most of the experts are still saying, although the group from Oxford has been talking that they may have a vaccination by September or October, most people seem to think it might be another year before we get a vaccination. So we're going to have to go through the winter period of 2020 and get through that. One of the things, remember, that's been predicted by the experts is that there could be a resurgence of COVID-19 on top of the flu season, which could overburden our health services, etc. So while we are reopening, which I think it's a legitimate thing to reopen our economies, our schools, etc., eventually, we have to bear in mind that our health care system should be prepared for resurgence of COVID-19. So there is a company that published some data this week, Moderna. The vaccination is called mRNA 1273. It's a small trial, only about 45 participants, but those who were given the vaccination tolerated it well. There were 3 doses, 25, 100, and 250 micrograms. And the people who were given the 25 and 100 seemed to do best. Those who were given the higher dose seemed to have developed some side effects of nausea, vomiting, etc. But those who were given the 25 and 10 developed antibodies to COVID-19, which is a good sign. And so ongoing trials are going on. In fact, there are about 90 vaccinations right now, 90 potential COVID-19 vaccinations on the study, and 6 of these are already being tested on human beings. So the whole push towards a vaccination is accelerating. I know there are several of my family members and friends as well who have said that even if a vaccination comes on the scene, they will not be taking it. Now, I respect that. I would be taking it, and if it could very well be that countries will say, if you don't take the vaccination, as the yellow fever vaccination. So let me just remind you, I remember about a few years ago, we were on the way to Costa Rica, and we forgot our international vaccination cards at home, got to the airport, and Copa asked us for the vaccination cards. Unfortunately, we had someone who could rush it up to us from our home. If we didn't have that vaccination card, we would not have been allowed to board the plane and travel to Costa Rica. So what's the difference between the yellow fever vaccination and a potential COVID-19? Now, can I say I spend a lot of time on Facebook, for better or for worse, and I was labeled arrogant recently for saying that people should be cautious about making statements about conspiracies without the necessary scientific training. Now, when you read an article, you need to be able to analyze what is the science behind this. Because someone goes on to Facebook or YouTube and begins to talk about all kinds of conspiracies, you need to be able to have a scientific basic knowledge to be able to analyze that data and say whether it is true or false. Now, it might be that it will turn out that some of these conspiracies were true, and we will see in time. But for the present time, as I say to many people who are on Facebook, it makes it more difficult for us as doctors. If a vaccination does come on the scene, I can already predict that many of you will come in and you would not want to take the vaccination because of the fear of side effects. So my opinion on COVID-19 is that a vaccination is absolutely important. One additional sign or symptom has been added to the some of the basic symptoms of COVID-19. It's the loss of taste and smell. The loss of taste and smell, there's a medical term for that, which I wouldn't go into. So the persistent cough, fever, and now the UK has added a loss of taste and smell to the symptoms. If you develop these symptoms, you should be self-isolating and for up to 14 days. And of course, they're trying to ramp up all the testing available for it. I just want to spend 1 or 2 minutes on the drug chloroquine. We know that just this week, the president of a certain country has said that he's taking chloroquine. And yesterday I was looking at the news, and, you know, we have to be concerned when someone is deliberately putting down scientific data as opposed to having a gut reaction. Now, everyone is entitled to take chloroquine if you so desire to do it. But to have a position of influence and to be saying that you're now taking that drug to prevent infection. So the trials that have been done with chloroquine, yes, have been done on patients who are not well, patients who are in the hospital setting, and it did not show much efficacy. Now, that study has been kind of, just yesterday, it was criticized as being the enemies of a particular regime that is in power. Now, I find that really amazing, as that statement, because it was done by scientists who do not, in my opinion, have playing partisan politics. Now, but the point is, it's not just one trial. There were 2 other trials in reputable journals, the New England Journal of Medicine and I believe the Lancet, that again re-emphasized that chloroquine did not have much efficacy in treating patients with COVID-19. The trials have not yet been done where prevent taking chloroquine as a prophylaxis. So what that particular person was saying is that he's taking chloroquine to prevent COVID-19, and there's certainly no trial data to say that that chloroquine can work. So just in this first aspect of the show, I'm kind of summarizing the latest data on chloroquine. I'm reminding you that the other thing coming away from chloroquine is in diabetics in particular, it seems that patients who contract COVID-19 have a higher risk of what we call ketoacidosis. So in the hospital setting, people with COVID-19, if they are diabetics, they are being, it's a better idea to put them on insulin if you're in the hospital setting, and if the patient is not well, and take them off metformin, and if they are on what we call the SGLT2 inhibitors, drugs like Jardiance, Invokana, Forxiga, those drugs should probably be stopped. But let me just say very quickly, though I'm saying that that's a category of patients who are not well and who are in a hospital setting and who are probably their oxygen saturations are low and they need to be managed, their diabetes need to be managed. It might be a better idea to put them on insulin therapy and take them off, especially metformin and SGLT2 inhibitors. Just 1 or 2 other points. The guidance we have received locally, I think the Caribbean on the whole, we have been getting a lot of praise. Our governments and Ministry of Health, they've been praised for the way they have handled the COVID-19 pandemic, and I think justifiably so. We've been able to really keep it at bay. I read just yesterday, though, that Haiti has had an upsurge in the number of cases in just one day. So that's a matter of concern. Before we go to our first break, I'll just kind of complete on COVID-19 and go into, after our break, our main theme today, which is on cardiovascular disease and diabetes. So I'm revisiting that for a particular purpose. So the wearing of masks, you know, there's a lot of controversy, and of course our Prime Minister made the statement, if you don't wear a mask, you will not be served. Now, I do agree that it's a good idea. Now, I want you to understand what I'm saying here. It's a good idea to wear a mask to prevent spreading the infection, COVID-19, and to maybe prevent getting the infection as well. So you're thinking not just about yourself, but you're thinking about people around you. But let me just say, the evidence for wearing masks is still a bit tenuous. The WHO has said it's a good recommendation. So as I've said to a few people, my understanding is that it's a good idea to wear a mask. I don't think it's the law, but you may find that if you don't wear the mask, you will not be able to get out into the public scenario, or you may not be served in the groceries, etc. Washing your hands, extremely important. Sanitizing, extremely important. And of course, not touching your face unnecessarily. Now, that's a very difficult thing not to do, because especially if you're wearing these masks, it's I find myself when I'm seeing patients, I'm wearing the mask and I'm constantly adjusting the mask. So how effective these masks are, it could very well be a kind of, when I say placebo, giving us a false sense of assurance. I think the social distancing bit is even more important. Wearing the mask is important, but social distancing is extremely important, and being sensible. So as restrictions are progressively being released or being relaxed, I think we still need to, as I've said to many people as a pastor, when we go back to having our services, it will be interesting to see how people are going to respond and how people are going to come together, if people are going to wear their mask, or if people are confident enough to gather together again. We're going to go to our break in a few seconds. So I've tried to summarize some of the latest data on COVID-19. If you need more information, you can ring us on 482-4269. We are not live tonight, but you can, in fact, the better thing to do is to WhatsApp your messages on that number, 482-4269, and then I can respond in a timely fashion. We go to our first break on Your Health, Your Choice.
Exclusively on ACTN The Voice. This is Messenger TV. Join us as John and Lisa Bevere equip and empower generations of Christians, both young and old, developing uncompromising followers of Christ who transform our world. Starting on Mondays at 8 a.m. with repeats to fit any schedule. Tune in, log in, or click on the Word like never before. Stay tuned for a new experience from the Word of God with Messenger TV, exclusively on ACTN The Voice.
Cloud 9 with your new hosts, Renata and Kimberly Singh. Weekdays at 5 p.m. on ACTN The Voice.
Welcome back to Your Health, Your Choice. Just want to remind you, we're not live. We've not been doing the live programs because of the restrictions of getting out at night. So these are taped programs, but you can call us on 482-4269. In fact, actually, preferably, you can WhatsApp your questions on that number, 482-4269, on COVID-19, diabetes, etc. So we're going to talk a little bit about cardiovascular disease, CVD, and the significant global burden that CVD presents to us. I'm going to ask Josh to bring up slide 4, which is our first slide. And this just shows us that the burden that and I'm going to explain to you what we mean by cardiovascular disease. But cardiovascular disease is a significant global burden. It's a significant global burden. These are figures from 2012, and over 56 million deaths worldwide. And out of that, over 31% was due to cardiovascular disease. And when we talk about cardiovascular disease, we see 7.4 million due to coronary heart disease, CHD, and 6.7 million due to cerebrovascular disease, or CV, cerebrovascular disease, or strokes. And we know there are several types of strokes. So we can just come off that slide. Now, the reality is that the link between cardiovascular disease and diabetes is a real one, as we have said on this program many times. And what I want to show you on the next slide is type 2 diabetes, slide 5, is increasingly prevalent. So on the left-hand side of the slide, you see that at the present time, there are about 415 million people worldwide living with diabetes. And it's projected in the next 20 years. So that 415 was in 2015. But by 2040, it's projected about 642 million people will be living with diabetes. And on the right-hand side of your slide, now, again, this is a matter of great concern that at least 68% of people over 65 years with diabetes die not of diabetes, but of heart disease. And you see the graph, which is a bit scientific, but the mortality risk of CV death with diabetes is quite high. And that's what that slide is showing. So what we are saying is that the prevalence of diabetes is obviously increasing. We know that. We know that, especially type 2 diabetes, it's increasing. And the reasons for that is multifactorial. We know that there's a strong, especially here in Trinidad, there's a strong genetic pool that is driving diabetes from one generation to another. So I often say to my patients that your diabetes is not just due to lifestyle factors. And this is one of the things I try to emphasize to my patients when, and even when I see things on Facebook about get rid of your diabetes by doing a ketogenic diet, for example, or by losing weight. I think those things, well, I'm not for the ketogenic diet, but certainly lifestyle changes where we go to a low GI diet, low glycemic index diet, and if you're overweight, losing weight can put your diabetes into remission and reverse some of the function of the beta cells. We now know that there's good evidence for this. But what I think a lot of people miss is the genetic link to diabetes. So, I say this so often. I see a lot of diabetics coming into my office who are actually quite slim and quite lean, and they don't have much body fat, and yet they have diabetes. And when you look at their family history, the family history is, mother and father, brothers, sisters, all have diabetes. And that diabetes is driven by the genetic link. So I want you to understand, and I'm passionate about this, that this is one of the things about practicing medicine. And I told a patient this just yesterday. She's quite conscientious. She looks after herself. She's exercising. She's eating healthily. yet her HbA1c, which is a 3-month blood sugar level, has been rising gradually. And yesterday I saw her and it was a little bit high. It was 7.8, which is high for her. And she was, concerned because she's a very conscientious person. And what I tried to hint to her is that she's struggling with her diabetes, not because she's not doing the right things. So I just want to push this home at this point that, we need as healthcare professionals not to make our patients feel more guilty and be shamed into thinking that they're not doing the right things, because very often patients are doing the right things, but the beta cells are genetically predisposed to malfunction, and therefore you need to read carefully into your diabetic patient, the history and the kind of patient before you, and you understand that the treatment for one patient is different to the others. I'm just going to bring up some of the key manifestations, slide 7, key manifestations of cardiovascular disease. So when we talk about cardiovascular disease, we're not just talking about the heart. So on the left-hand side, you see coronary artery disease, diseases of the blood vessels supplying the heart muscle. You have peripheral arterial disease, diseases of the blood vessels supplying the arms and the legs. You have, on the right-hand side, stroke caused by disruption of blood supplying the brain. And then you have what we talked about on the last slide, last 2 weeks ago, heart failure. The heart, and let me just say, heart failure is failure of the heart to pump blood with normal efficiency. And it's one of the complications of diabetes that we are recognizing more and more. So we can just come off that slide for a minute and explain to you why we are so concerned. Because we know that diabetic patients have a higher risk of cardiovascular disease. And when we talk about cardiovascular disease, in fact, just today before I came here, I had a call, not from a patient, but somebody who knows me. And when they rang me, I was not available, and I called back, and she then informed me that she had just had a stroke. And she has 2 risk factors, diabetes and hypertension. Diabetes and hypertension. And she admitted that her blood pressure had not been well controlled for a period of time. So with diabetes and hypertension, as we will see, you have 2 major risk factors for cardiovascular disease. So we know about coronary artery disease, and can I just say that a lot of work in diabetes care is trying to prevent patients from having heart attacks or myocardial infarctions. And you would find that patients who are relatively young, and when I say relatively young, in their 50s, I call that relatively young now, or the early 60s, having their first heart attack. And remember, when you have a heart attack, you damage your heart muscles, which can then lead to heart failure. And of course, there are different grades of heart failure. And now there are drugs, new drugs in the market, the SGLT2 inhibitors, coming out from the EMPA-REG trial and other trials that is showing that these drugs give extra protection against heart failure and myocardial infarction, etc. So we have coronary artery disease, we have peripheral vascular disease, that's the blood vessel flow to the legs, and then we have heart failure, and of course strokes. That's one of the things that we should be very aggressively pursuing, trying to prevent strokes in our patients. The next slide, slide 8, goes on to talk about the complications of what we call microvascular and macrovascular complications. So type 2 diabetes is a major and independent risk factor for both microvascular and macrovascular complications. Now, I'll explain to you in a minute what I mean by microvascular and macrovascular complications. But again, on the left-hand side of the slide, you see the macrovascular complications affecting the brain and the heart. Those are the large blood vessels. And on the right-hand side of the slide, you see the eyes, the kidneys, and the nerves. That last circle is referring to the nerve end. So I'm just going to come off that slide and talk about that for a minute. So diabetes will not only cause damage through affecting the large blood vessels, causing what we call macro means big or large, macrovascular complications of diabetes, but it can affect the small blood vessels due to what we call endothelial dysfunction. Endothelial dysfunction, that's a big medical term. What diabetes will cause is inflammation of the arteries, so that the walls of the arteries are affected, preventing vasodilation. So it can cause thrombosis, vasodilation, endothelial dysfunction. So you have a process of active inflammation going on in the arteries. And this is, why diabetes can be such a deceptive problem. And hypertension. We use the word silent killers, and I don't particularly like that term because it will strike so much fear and anxiety into many of our patients. But you have to remember that diabetes and hypertension and hyperlipidemia can cause silent damage to the walls of the arteries. It's not just causing disruption of the layers of the walls of the arteries, but it's causing endothelial dysfunction, oxidative stress, and as a result of that, you have plaque buildup causing macrovascular complications, strokes and heart attacks, peripheral vascular disease, but then what we call microvascular disease affecting the eyes. So we advise all diabetics, and I want to say even in the midst of COVID-19, you should still be having your eyes examined at least once a year if you're a diabetic by an optometrist or an ophthalmologist. You should have your eyes dilated, and you should have a good eye examination. And lots of the optometrists are now doing retinal photography, and I know we have retinal photography in some of the health authorities. So we want to protect your eyes. We want to protect your kidneys. Big problem. Hypertension and diabetes, two of the major risk factors for chronic kidney disease. And remember, when the damage is done to the kidneys due to chronic kidney disease, you can stabilize the kidney, but a lot of the damage cannot be reversed. So we want to pick up on early signs, and due to endothelial dysfunction, one of the early signs of chronic kidney disease is testing the urine for what we call microalbuminuria. So many people ask, why are we testing your urine? I'm not testing your urine for glucose. I'm not really interested in that. We can test your urine for ketones, more in type 1 diabetics. But what we test the urine for is protein, and not just the normal dipstick test in the doctor's office. We send a spot urine sample off to the lab, testing for microalbuminuria. And we are looking for between 30 to 300 milligrams of protein in the urine, which is called microalbuminuria. Macroalbuminuria is above 300 milligrams. And what we want to do is protect your kidneys. And the way we do that is good sugar control, good glycemic control, good blood pressure control, and good cholesterol control. Those three factors go hand in hand. And of course, nerve end dysfunction, what we call neuropathy. So the most common form of neuropathy is peripheral neuropathy, of course, where people get burning and numbness in the feet, very painful feet. But there's also autonomic neuropathy, which is autonomic neuropathy can cause arrhythmias to the heart, can cause erectile dysfunction, can cause gastroparesis. So autonomic neuropathy can present in various forms, and we're trying to protect the feet to prevent amputations, diabetic foot ulcers, etc. Slide 9, I think we may have to go to a break soon, but slide 9 talks about this concept of endothelial dysfunction. which is common in macrovascular and microvascular disease. And so I just want to go to the next slide, slide 10, quickly. So the whole problem with endothelial dysfunction is you see plaque buildup. So if you go from the left to the right, you see plaque being built up, and the artery on the left, that's maybe a young person, the artery is fairly clear, and then progressively you see plaque being built up. And the interesting thing is, maybe not till you get to the end on the right side, you might start having symptoms of chest pains, but very often this process of atherosclerosis, a big medical term, atherosclerosis, is a silent process, but it's accelerated by type 2 diabetes, by hyperglycemia, what we call insulin resistance, inflammation, and diabetic dyslipidemia. So I'm just going to come off that slide because I just gave you some fairly big terms there. So the process of atherosclerosis, which is building up of plaque in the arteries, is accelerated by hyperglycemia, which is a high blood sugar, by diabetic dyslipidemia. And what I call diabetic, what do we mean by diabetic dyslipidemia? The typical dyslipidemic pattern in diabetics is that your total cholesterol may not be too bad, but your triglycerides are raised, your HDL, which is your good cholesterol, is low, your LDL, which is your bad cholesterol, may not be too bad, but your VLDL, that's the very low density lipoprotein, that can also be elevated. So the typical diabetic dyslipidemic pattern, so that's why if you go to a drugstore and just do your total cholesterol, you may think it's okay, but your triglycerides could be very elevated. And I see quite a few diabetics with relatively normal total cholesterols, but their triglycerides are high because, again, people with abdominal adiposity, which I'll come to in a minute, release a lot of free fatty acids, and the free fatty acids drive the production of triglycerides, and also there's a genetic trait in the production of triglycerides. Your HDL, which is your good cholesterol, could be low, and the VLDL could be high. And of course, we have this term called insulin resistance, where the body is not responding to the insulin, so your body is producing more and more insulin, and even that we know can have a negative effect on the process of atherosclerosis. So decreasing insulin resistance is an important concept, and of course the whole process of inflammation. So we see this relationship between diabetes and cardiovascular disease is a very complex one, and one that needs to be managed by managing what we call risk factors. So we're going to go to our second break in a few seconds, but one of the things we struggle with is what we call the pill burden, patients having to take so many pills, and I'm going to come back to that when we come to our last segment. I know there's a whole thing about Big Pharma, but just hold on. I'm going to come back in a few seconds, or a minute or so, to Your Health, Your Choice. We're going to go to our second break tonight. Stay with us, and we'll come back in a minute or two.
Every Sunday at 2 p.m. on ACTN The Voice, we'll be taking you on a journey down memory lane with our Sunday classics. Relive the moments. Bonanza at 2 p.m. Little House on the Prairie at 3 p.m. Gilligan's Island at 4 p.m. Family Matters at 4:30 p.m. Hogan's Heroes at 5 p.m. The Jeffersons at 5:30 p.m. This is Sunday Classics on ACTN The Voice.
Exclusively on ACTN The Voice. This is Messenger TV. Join us as John and Lisa Bevere equip and empower generations of Christians, both young and old, developing uncompromising followers of Christ who transform our world. starting on Mondays at 8 a.m. with repeats to fit any schedule. Tune in, log in, or click on the Word like never before. Stay tuned for a new experience from the Word of God with Messenger TV, exclusively on ACTN The Voice.
Cloud 9 with your new hosts, Renata and Kimberly Singh. Weekdays at 5 p.m. on ACTN The Voice.
Welcome back to Your Health, Your Choice. I just want to remind you that we are doing pre-recorded programs because of the COVID-19 situation. Tonight we started off with COVID-19, some of the latest trends, and we're now talking about cardiovascular disease, the burden of cardiovascular disease with diabetes. And what I've been trying to demonstrate is the complex interaction of risk factors that lead to excessive mortality and morbidity if you have diabetes and cardiovascular disease. So the point we've been making is that diabetics have a higher risk of death from macrovascular and microvascular disease, but diabetics also have a higher risk of having coronary artery disease. And the reason for that is the combination of hyperglycemia, insulin resistance, associated hypertension, and of course a diabetic dyslipidemic pattern. Just to remind you, because we're not live, you can WhatsApp your questions on 482-4269, 482-4269, because I'm giving you a lot of scientific information here tonight, and you may have questions, and I try to return the calls, or at least return on the messages if you have questions, 482-4269. The other complex interaction is what we call visceral adiposity, and slide 11. It's a little bit of a complex slide, but I just want to show you why we make such a big deal about being overweight. I know the term obesity is not a nice term, and people don't like using that term. But the fact is that people who are overweight produce what we call lower levels of adiponectin, adipocytokines, and increase inflammatory cytokines. So those are three hormones or enzymes that two of them, the one on the top, it's decreased production, and the two others increased, leading to type 2 diabetes, insulin resistance, and then you have the list of problems that, so you're starting with obesity now. We're saying people who are overweight have these enzymes not being produced, or too much of it being produced. That then leads to a higher risk of type 2 diabetes and insulin resistance, which then leads to dyslipidemia, endothelial dysfunction, hypertension, and as you get older, the process is accelerated, and what we call increased oxidative stress, the last box, very important term, increased oxidative stress, and then atherosclerosis. So we can come off that slide, and I just want to, really push home this whole aspect of treating all these conditions. So yes, we're talking now about obesity, and of course we know the main thing about dealing with people who are overweight are lifestyle changes. So I've been trying to encourage my patients that in spite of the lockdown, well, the lockdown is now relaxed and we can go out walking. I know gyms are not allowed to be open as yet, but you can walk. I have to say, little halo over my head. I've been exercising much more. I've got into a routine now. So even yesterday, my wife and I went out walking for about 20-25 minutes, got back home. I even did a little bit of running. And then, so I'm telling you what I'm doing. I'm not telling you to do something that I'm not doing myself. did a few squats, and then a little bit of weights, push-ups, and sit-ups, etc. About 45 to 50 minutes. And I'm now doing that about 5 to 6 times a week. Now, if at my age, I can be doing that, those of you who are in your 20s and 30s, there's very little excuse. So I'm being a little bit hard on you here now. There's very little excuse. Now, I know there was a big sense of excitement with the reopening of the fast food outlets. I'm not telling you you can't have doubles or you can't have the other fast foods. I don't want to call them by name. But, of course, food portions are very important. And can I say that with obesity comes changes in the hippocampal area of the brain, where you lose the concept of what a normal food portion should be like. So you might think that 5 doubles is a normal pattern of eating. I want to tell you, no, it's good for the doubles people, but it's not good for you. 1 doubles should be enough, really. I know some of you will want to shout at me and throw stones at me through the camera, but you can retrain your appetite. Can I say that? I'm passionate about that. You can retrain your appetite. You can retrain yourself to eat less salt, less sugar. I'm not into telling you the draconian methods of cutting everything out. No, we're not here to punish you. But you can control your food portions, and you can retrain yourself to eat properly and to exercise. And now, particularly if you have diabetes, we have groups of drugs like Jardiance, Forxiga, Invokana. These are the SGLT2 inhibitors. We are also waiting on the GLP-1 agonist, something called Trulicity, that can actually help you lose weight. The way they act can help you. You have decreased satiety, decreased appetite, increased gastric emptying, the GLP-1s in particular. And both of these groups of drugs can help you lose weight. So now I know some of you will be talking about big pharma, but can I just say that, yes, the pharmaceutical industry is a big industry. And just coming back, because I know we're going to draw to an end in a few minutes on this program, there's so many people who are talking about the evils of vaccinations. I want to remind you again that vaccinations have been one of the most important medical breakthroughs in the last 100 years. For me, insulin, Banting and Bess, 1920, discovered insulin. It was produced. Insulin has saved millions of lives. So if we use insulin in the right way, we can save lives. Similarly with vaccinations, smallpox was eradicated due to vaccinations. Polio almost eradicated due to vaccinations. TB almost eradicated, but then a resurgence due to HIV and other immunocompromised conditions. We have the MMR vaccination. Now, I know some people, some parents have been made to think that there's this strong link between measles and vaccination and autism. That has been debunked repeatedly. The problem is, once something gets into the airways and on Facebook and all the electronic media, as healthcare professionals, we are fighting an uphill battle. But the fact is, immunizations have saved millions of lives. I want to suggest to you as well that a lot of diabetic medications, metformin, a simple drug, metformin has a bad name amongst so many people, but metformin has saved millions of lives. Cholesterol tablets, not everybody needs a cholesterol tablet, but all of you who think that cholesterol tablets damage your liver and does all these kinds of things like Alzheimer's, etc. What do you have to weigh up? Every single tablet. Can I just say, I'm waxing philosophical now because I'm soon going to put on my pastoral hat. Every single action you take, be it to take a tablet or not take a tablet, take insulin or not take insulin, can have effects either way. What you have to do is weigh up the advantages and disadvantages of taking a particular medication. And if you have all these risk factors, so I say repeatedly, doing medicine is an art. It's not just science, it's an art. So when a patient comes in, if a 25-year-old patient comes in with a high cholesterol, I'm probably not going to put them on aspirin. I'm not going to put them on a cholesterol tablet at 25 years old. I'm going to emphasize lifestyle changes, etc. Even if they are diabetic, I may put them on diabetic medication. But if that patient is 60 years old, you can do what is called a cardiovascular risk analysis. There are various risk engines on these smartphones that we have. I can plug in the data, their age, ethnicity, male, female, the blood pressure reading, their cholesterol readings, whether they are smokers or non-smokers. And then you can do, just press a button and you get what is called a 10-year cardiovascular risk for that patient. And cardiovascular, by that I mean heart disease as well as strokes. And then that tells you whether that patient should be on aspirin, whether that patient should be on a statin. So very often I do that for patients. I bring up on Google the cardiovascular risk engine from the American Heart Association and the American Medical Association, and I plug in the data and I show patients the risk, and then I say, here's your risk. If it's above 7.5% or above 10%, as the case may be, you need to be on a statin or you need to be on aspirin. This is not guesswork. This is not just kind of hocus-pocus medicine. This is what we call science based on double-blind, placebo-controlled trials. I know we don't probably have much more time, but I want to bring up slide 17. Slide 17. And this is quite a, well, it's a visual image of what life expectancy, the fact that life expectancy is reduced by 12 years in diabetic patients with previous cardiovascular disease. So if you look at that slide, at the top, you take it from 60 years old. If you have no diabetes, you probably have a lot of years ahead of you. If you have diabetes, your risk decreases by 6 years. And if you have diabetes and cardiovascular diseze, your risk goes down by 12 years. So you know, I really want to push that home to you as we kind of try to bring some of this to a close, that diabetes, you're losing about 6 to 7 years of your life, and diabetes and cardiovascular disease, you're losing almost 12 years of your life. Now, those are really stark figures, and they remind us that diabetes, hypertension, etc., are not just mild diseases. They are not just lifestyle diseases. They are things that we need to address very, very aggressively. Now, slide 23. Slide 23. I'm going to bring that slide up. Slide 23. And sorry, slide 24. Let's just go to slide 24. Right. So, as I try to kind of summarize what we are talking about, so these are what we call the modifiable risk factors in type 2 diabetes. The modifiable cardiovascular risk factors. These are the things we can address in our diabetic patients to try and prevent cardiovascular disease. Hyperglycemia, which means a high blood sugar, hypertension, dyslipidemia, and obesity. We can just come off that slide. So when we talk about hyperglycemia, we have certain targets we work towards, and it's not a fixed target for everyone. So can I just remind you that what we call the HbA1c, which is a 3-month average of the blood sugar, 6.5% is not appropriate for everyone. That's the goal. But if someone is 80 years old with heart disease or kidney disease, I'd be happy with an A1C of 7.5 or even 8%. Hypertension, your blood pressure, we should be aiming for about 140 over 80. If you have kidney disease, even lower than that, 130 over 80. Dyslipidemia, we have the figures that we work to, getting your HDL over 50. That's a good cholesterol, your LDL over under 100. And of course, obesity, we have what we call the body mass index that we work towards. We have less than 3 minutes left, and I'm just going to close up on this. So tonight we have talked about COVID-19 and some of the latest developments, and we have also talked, the major part of the program has been on cardiovascular disease and diabetes, emphasizing to you in the midst of COVID-19, you should not ignore your diabetes, hypertension, hyperlipidemia. They still need to be treated. You can ring us on 482-4269, 482-4269 for further information, for medical appointments, or just if you need more information, I'm willing to talk to you over the phone. Let me put on my pastoral hat as I close. Over the last week and over the next few weeks, we are still having our Sunday services online from the Anaposis Chapel at 9:30 a.m., the Trinidad and Tobago Anaposis Center, Facebook, and lots of you have been joining us. I want to thank you for joining us, and I've been talking about divine direction. And the one tagline I want to leave with you today, and I think I've said this before, the decisions we make today will determine the stories we tell tomorrow. Now that's powerful, even if I were to say, and that doesn't come from me. That's a wonderful tag from Craig Groeschel, a book called Divine Direction. Many people are asking in this season of life, what is God saying to me? What does God want me to be or to do? Does he want me to be a doctor, a lawyer, a plumber, electrician, or pastor, evangelist? Can I say, long before you think about what you do, God wants you to become the real who. What do I mean by that? God wants you to become the real thing. You see, your conduct flows from your character. When the lights are down, when no one else is around, who are you really? We can fool some people some of the time, but we can't fool God. God sees us as we are. We need to be transparent, authentic, full of integrity. So as I close up on your health, your choice, let me leave you with this tagline. The decisions you make today, and some of you have crucial decisions to make today, will determine the stories you tell tomorrow. Don't play the blame game. Don't blame your parents, a spouse, someone else for the outcomes in your life. Live your life by taking responsibilities for making wise decisions. You have been looking at Your Health, Your Choice. This program will be replayed, and we will come back with another program hopefully in 2 weeks' time. Thank you for joining us tonight. I'm Dr. Claude Kahn on Your Health, Your Choice.